Hello, my name is Aslam Ejaz. I'm an assistant professor of surgery in the Division of Surgical Oncology at The Ohio State University. And it's a pleasure to be speaking with you today regarding the management of malignancies presenting with emergent symptoms. I have nothing to disclose. There has been a steady decline in death rates from cancer beginning in 1991, largely due to improved prevention methods such as smoking cessation, improved screening methods, and treatment modalities, both systemic and surgical. However, the incidence of cancer has remained relatively stable over the past several years, and there's an estimated 1.8 million new cases per year. While the majority of these patients are diagnosed through these screening methods, a number of patients will present with acute symptoms. And so this was a review article looking at cancer patients who presented to the emergency department with acute symptoms related to their cancer. And as you can see, a number of them present with symptoms that potentially are surgical. And so bleeding, hemodynamic instability, GI symptoms, nausea, vomiting, ileus are all common findings in cancer patients, particularly in those with GI cancers. Over one half of all emergency department visits for oncology-related symptoms will result in an admission to the hospital. And more importantly, mortality rates for these group of patients can be up to 50%. So to categorize the problem for patients presenting with malignancy-related symptoms, often categorized based on the type of problem. And so they can be metabolic, hematologic, cardiovascular, infectious. But I'm going to focus today on structural problems or those that are potentially surgical. And the three main areas in which these problems can present are related to obstruction, perforation, or bleeding. Now, before I get into the management of these symptoms, I wanted to discuss palliative care consultation and early goals of life discussions. Now, again, a number of these patients will initially present with their cancer with an emergent symptoms, but for patients who are already diagnosed, early to palliative care consultation can result in improvements in quality of life, symptom management. It can reduce caregiver burden, but more importantly, they can decrease aggressive end-of-life care interventions while also possibly increasing survival. And so there have been a number of trials on this, and this is the most recent trial that is currently enrolling. It's titled the Periop PC trial, and this trial randomizes surgical cancer patients to early palliative care consultation versus not, in determining whether or not patients will benefit from this. So one of the most common causes of acute emergent symptoms is malignant bowel obstruction. And so malignant bowel obstruction can have high morbidity rates up to 50%. In patients in which it resolves, reobstruction rates are also very common, up to 50%, and mortality rates can be up to 25%. And really the key finding here is that location drives management. And so patients can present with single sites of disease, which are more favorable, versus multifocal or extensive disease, which can occur in patients who have peritoneal carcinomatosis. And so in these patients, management is much, much more difficult. And so often medical treatment is a first treatment option, and this includes making the patient NPO with IV fluid resuscitation and NG tube decompression to decrease the intraluminal pressures. And antiemetics, analgesics can be used for symptom control. And steroids such as dexamethasone and octreotide have also been shown to be beneficial in certain patients in some studies. And this may result in spontaneous resolution of malignant bowel obstruction in up to a third to one half of patients, again, depending on the type of obstruction and the extent of obstruction. In patients who don't experience a resolution following medical treatment, next option is often endoscopic management, which I'll get into a little bit more in detail later. But patients who benefit the most from endoscopic management often have a single site of disease and more likely to be successful if this disease is in the duodenum as opposed to the colon, for instance. Endoscopic management can also be used to palliate symptoms through a palliative PEG, in which in patients who have a very short life expectancy or who are very frail. And finally, surgical management is also an option. And so upper GI obstructions can be caused by intrinsic or extrinsic compression from the tumor. However, treatment-related edema, such as those receiving chemoradiation therapy, can also cause obstruction. And so gastric outlet obstruction, either due to a distal gastric tumor or a duodenal mass, can often be relieved through a duodenal stent versus a surgical gastrojejenostomy. And so duodenal stents compared to gastrojejenostomy treatment have very similar rates of success and can be over 90% successful. However, late recurrences can be higher among patients who just receive a duodenal stent. And so in patients who are very frail and have a very short life expectancy, as well as those who have a long life expectancy over 6 months, duodenal stents are not recommended. And the late complications that can happen include stent migration, occlusion, bleeding, and perforation. And so in patients who have a longer life expectancy and favorable anatomy and are eligible for a bypass, a gastrojejenostomy is the best option. And so the surgeon has to take into consideration the patient's performance status, their nutrition, and whether or not they've received chemotherapy recently. And often these can be performed through minimally invasive surgery. And so at our institution, we try to perform these bypasses if necessary, either through a laparoscopic or robotic approach. Finally, resection is an option in patients who have good performance status, who have a clearly resectable tumor and are presenting with an obstruction. And so resection plus primary anastomosis is an option in these patients. Biliary obstruction can occur most commonly either due to a ampullary, duodenal, or pancreatic mass. And so the preferred management of a biliary obstruction, acute biliary obstruction, is endoscopic decompression via ERCP. In patients whom this is not possible, percutaneous decompression is the next best method. And finally, very rarely, surgical decompression may be necessary. And often the times where this is most successful is when the level of obstruction is low, so below the bifurcation of the hepatic ducts, in patients with good long-term prognosis, and those, again, who have good performance status and who have not received any type of systemic chemotherapy or targeted agents recently. Lower obstruction is often divided based on the location of obstruction. And so this is the 2017 guidelines from the World Society of Emergency Surgery. And in this pathway, it's divided between right, left, and rectal cancers. And so in patients with right-sided tumors, whether they're stable or not really helps determine management. And so in unstable patients, either primary resection with ileostomy or just ileostomy alone can be considered, and that's considered a damage control operation. In patients who are stable with a clearly resectable tumor, a right colectomy with anastomosis is the best option. However, if curative intent resection is not possible, then either colectomy or bypass or a loop ileostomy should be considered. For patients with left-sided tumors, management is very similar. However, in patients that are not eligible for curative intent surgery or who may need systemic therapy up front, a self-expanding metal stent is also an option. Rather than a loop ileostomy, if patients are unstable or resection is not possible, then a transverse loop colostomy is the preferred method of decompression. And in patients with rectal cancer, often colostomy in the form of a transverse loop colostomy are preferred, as these patients often will need neoadjuvant either chemotherapy or chemoradiation therapy prior to surgery. Perforation, in patients who are presenting with perforation, the main objective is to control sepsis. And so damage control strategies are an option in unstable patients. If it's a contained perforation and the patient is stable, IR drainage or percutaneous drainage is a good option. However, where there's no window or this is not a good option, either laparoscopic or open drainage, washout and drainage is a good option. And for patients who have a resectable tumor and minimal to no spillage and no evidence of sepsis, then a curative intent resection can also be performed. Most common causes of bleeding from tumors are due to local invasion, vessel damage, or treatment response and coagulopathies. And so step of management is resuscitation of the patient and reversal of any coagulopathy that may or may not be present. An endoscopic approach for either bleeding tumors of upper or lower the GI tract is preferred. However, this can be limited based on the amount or extent of bleeding. And so in cases where this is not possible or not successful, angiography or embolization is the next preferred route. For certain tumors, such as bleeding hepatic tumors, angiography or embolization is the primary method of treatment. Radiation therapy can be considered in certain circumstances and when there's a localized site of tumor bleeding. And certain systemic therapies, such as TKI for patients with GIST, can be used to help control bleeding as well. And so surgery is often reserved for patients with persistent hemodynamic instability, recurrent bleeding, or failure of these non-surgical therapies. So in conclusion, surgical emergencies in cancer patients are common and can result in high morbidity and mortality. Early goals of care discussion should be had in a non-acute setting if possible. And several factors must be considered when determining management strategies, including the patient's presenting condition, their performance status, their long-term oncologic prognosis, and the severity of the acute problem. Thank you very much.